Good afternoon, everyone, and welcome to this important session in honor of Breast Cancer Awareness Month. Today, we are privileged to have with us Dr. Rani Nangia, Associate Professor of Medicine at Baylor College of Medicine. Dr. Nangia is board certified in both internal medicine and medical oncology with extensive expertise in breast cancer care. So, Doctor, thank you for being here with us today.
Thank you for having me.
So let's dive right in with our first question. We're going to start with the everything related to hereditary breast cancer. Please, can you explain the role of genetics that the genetics play in the development of hereditary breast cancer?
Yeah, so hereditary breast cancer is really important for a couple reasons. The first is this can really explain some families that have a lot of breast cancer, not just breast cancer. A lot of times there can be patterns of different cancer, for example, ovarian, pancreas, prostate, melanoma. And there's also some like different colon cancer syndromes and other things. So
Mhm,
whenever we see a lot of cancer or clusters of cancers in families, we worry about hereditary cancer syndromes.
mhm,
And it's important to recognize hereditary cancer syndromes because it can affect two things. When a patient's diagnosed with a cancer, it can affect the medications and the treatment plan that we develop for them, as
mhm,
well as the surgical plan. And then for family members, we really encourage what we call cascade testing so
mhm.
that the family members can be aware that these genes exist and we can make sure that they get tested and screened properly so we can either prevent cancer in the first place or detect it at very early stages.
Mhm. So, what are the most significant genetic mutations associated to the increase of risk in breast cancer that can
Yeah,
be
so the
detected,
most
I mean?
Yeah, so now there's actually these multi-gene panels that we order, and most of them are anywhere from like 19 to like 50 plus genes.
Okay.
But the most common genes that have like the highest rates of breast cancer are the BRCA1, BRCA2, and PALB2 mutations. And then there are some what we call moderate risk genes. So the most common moderate risk genes are like CHEK2 and ATM. And there's many others that can have like higher risks but are more rare, but these are the more common ones that we see.
Mhm. And doctor, how do you counsel patients with a family history of breast cancer? I mean, how do you approach them if they know they have the genetic, they are positively genetic after the genetic testing, I mean, if they are positive
Yeah,
for
so
this,
this is
the
actually
mutation.
this is actually a big part of what I do. So at Baylor College of Medicine, we actually have a cancer prevention clinic and program.
Mhm,
And so patients with family history can come in and we do a dual appointment with our genetic counselor and a physician. And in this appointment, what we offer is several things. First, a three-generation family history or pedigree is obtained. And we see, does this patient or their family meet criteria for genetic testing? And if so, we offer it. Most of the time, insurance will cover it, but if they don't, there's self-pay rates.
okay.
And then from that family history, we also collect some personal information, mainly related to hormone exposure. So when they started their periods, if they had pregnancies, when they
Mhm,
went into menopause, and we run these risk models that give us a 5 or 10 year risk and a lifetime risk for breast cancer. And from those models, we can see if they would benefit from medications for prevention. We call that chemo prevention,
mhm,
or if we can increase the screening we do. So, for example, instead of just doing a mammogram, we add in an annual breast MRI
yeah.
because there's studies that have shown if the lifetime risk is more than 20%, there's benefit from doing that.
Mm.
So in this visit, it's kind of a one visit where the patient can leave knowing if they need genetic testing and if there's things they can do like medications or the extra screening.
So this is the first time I hear about the chemo treatment for prevention. Can you tell us more about this?
Yeah, so it's not chemotherapy. So any
Yeah,
medications used for prevention we call chemoprevention. And the
prevention.
most common drugs are tamoxifen and raloxifene.
Okay.
So for premenopausal women, the only option is tamoxifen.
Mm-hmm.
And when we use this for breast cancer, we use a dose of 20 milligrams a day or 140 milligrams a week. In
Mm-hmm.
the prevention setting, I often do like 10 milligrams 3 times a day. There's some studies from Italy with as low as 5 milligrams every other day.
Mm-hmm.
So every center does this a little bit different. In the US, it doesn't come in a 5 milligram pill, so it just makes sense to do the 10
But
milligram.
these treatments are also used the post treatment also from cancer. Yes, they
Yes,
are
but
the same.
it's the same medicine,
Yeah.
but much lower doses. So
Okay.
you don't see the same side effects. So
Mm-hmm.
they're much better tolerated. And
Mm-hmm.
then for postmenopausal women, there is a medicine called raloxifene
Mm-hmm.
that you take daily. But women really like that because it also treats osteoporosis and kind of protects the bone health.
Mm-hmm.
And so I think by the time someone comes to see someone like me, they're pretty motivated and want to do something to prevent breast cancer. So in my clinic, about 80% of women will opt to take these medications if they're eligible. But it's been shown, at least in the US studies, that the uptake rate's only about 20%.
Mm-hmm.
So there needs to be, we can definitely prevent a lot more cancers if there was more uptake of these medications. But I think people don't like taking medicines they don't need to take. They're afraid of the side effects. So I
Yeah.
think there's a big kind of education component there. Mhm.
And doctor, what is the percentage of, for example, after a genetic test, if it's positive for BRCA1 or BRCA2, what is the percentage of women will have breast cancer during her lifetime?
Yeah, so that is very variable by country because of the criteria they
Mhm.
use. So in the US, the criteria is very loose and almost anyone with, a couple family members or certain types of breast cancer can get tested. So the positive rate's less than it's probably around 5%.
Okay.
But when we first started genetic testing at our clinics, we started in 1999 in our like kind of indigent uninsured hospital.
Mhm.
And our initial positive rate was like 50% because our criteria was so high.
Okay.
So it really just depends on the country's criteria. And I've seen anywhere from like 5 to 20%.
Mhm. Mhm. And doctor, for breast cancer prevention, what are the most important lifestyle changes that can women do to reduce the risk of developing breast cancer?
Yeah, so that is a very important question because that's what we can actually change, right? What we do.
True.
And so, what has been shown is several things. The first is regular exercise independent of weight. And
Hmm.
the recommendation is the same as with heart health. It's 3 to 5 hours a week of walking. So, half an
Okay.
hour every day, an hour every other day. And if you run or do more vigorous exercise, you can do less than that to get the same benefit. In postmenopausal women, it's been shown that obesity is a risk factor, and I think it's important to understand why.
Hmm.
So when you're premenopausal, most of your hormones are coming from the ovaries.
Yeah.
But when you're postmenopausal, most of your hormones are actually coming from hormones and body fat that get
Hmm.
converted to estrogen. So
Hmm.
it's been shown that people that are obese or overweight have a higher risk. And I think when women understand it, they're more motivated to, reduce
Lose
that
weight.
weight.
Yeah. Yeah.
And then the last thing is alcohol. So they have shown in women who have more than 3 drinks a week that that can increase breast cancer risk.
Hmm.
And in women who do drink alcohol, the vitamin folic acid is likely protective from a bulk of data that's out there. And I usually recommend it at the dose of 800 micrograms a day.
Okay.
Or you can take a prenatal vitamin that doesn't have iron, or just eat a salad every day because greens have a lot of folic acid in it. But
Hmm.
those are really the key things women can do.
Hmm.
In addition to the screenings, right?
Yeah.
So make sure you get your mammograms and regular screenings.
Hmm. And doctor, we know that the role of hormonal therapy in breast cancer, premenopausal and menopausal women lose certain hormones after this. So, and these hormones are crucial for their health in general. So, but many recent studies have shown that, the studies shown that if you take hormone replacement, your risk of breast cancer will increase. And some other studies, they say the opposite. So, what can you tell us about this?
Yeah, so I think it's a very nuanced subject, so I'm glad you're
Yeah,
asking. So when women have, so I think let's talk about premenopausal women first, because
yeah,
that's a little bit
okay.
easier. So birth control is safe. If there is any risk, it's very small and intermittent.
Mm.
So low dose combination birth control should not increase risk. There was one meta-analysis that showed perhaps a slight risk, but I don't think anyone's really worried about that causing a
Mhm.
significant risk. It more regulates hormone than increases or replaces hormones.
Okay.
In postmenopausal women, there are two main types of hormone replacement therapy.
Hmm.
The most common type is what we call combination hormone replacement therapy, and that's when we give both estrogen and progesterone. And when you have an intact uterus, so if you have not had a hysterectomy, your uterus is intact.
Yeah.
If we give what we call unopposed estrogen without progesterone, it can cause uterine cancer. And
Okay.
so that's why we do what we call combination hormone replacement therapy. And that is what has been shown to have an increased risk of breast cancer, especially if you're on it for more than 5 years.
Hmm.
So when I see women, especially if they've never had a breast cancer, they don't have a strong family history, if they want to take combination hormone replacement therapy for, up to 5 years to get through menopause symptoms, I think that's very reasonable. If
Okay.
they're worried about breast cancer risk, I do not recommend prolonged use.
Okay.
Okay.
Hmm.
And there's some women that accept the risk of prolonged use, and that's okay too, because there are benefits for heart health and bone
Yeah.
health, although it can cause this breast cancer risk, right?
Hmm. Hmm.
Now, what's very interesting is what's been pretty clearly shown in multiple studies now is that estrogen only hormone replacement therapy is actually likely protective of breast cancer. So the exact opposite, and this is where those discrepancies you've heard of are
Yeah.
coming from.
Mhm.
But it's only really safe to do that type of hormone replacement therapy if women have had a hysterectomy, that they don't have the uterus.
Okay.
They can have their ovaries in, but just not the uterus.
The urinary. Okay.
And so that's really the big difference that we see there. And it kind of makes sense to me because if you look at countries that have like soy-based diets or estrogen-based diets, like Japan, for example, they have much lower rates of breast cancer. And it's
Hmm.
been mixed results in studies trying to mimic it, but they're not like lifetime exposures to these treatments. So I do think it's a real effect that we're seeing. And so I think if someone wants hormone replacement therapy, that's a discussion they have to have with their physician about the pros and cons of
Mhm.
it.
Mhm. And doctor, can you tell us about the latest screening tools uh, for preventing breast cancer at an early stage, I mean? And at what stage, at what age should women start screening for breast cancer?
Yeah, so I think this is also a like nuanced approach. So
Hmm.
if there's no family history, most of the guidelines recommend starting between the age of 40 and 50
Okay.
and every 1 to 2 years. And then between 50 and 75, every 1 to 2 years. And after 75, kind of based on health.
Hmm.
Now, there are some nuances there. So, for example, if someone had a sister who had breast cancer at 45,
Yeah.
we recommend starting 10 years before the age of a first degree relative, so at 35.
Okay.
And if someone had strong family history and was found to have a hereditary condition like BRCA, we would
Yeah.
start at 25.
Okay.
And then if the lifetime risk on these models is over 20%, we would recommend considering to add in additional imaging.
Mm-hmm.
Um, MRI is kind of the best additional screening, but not all centers have MRI, so then ultrasound could be substituted in those cases.
Mm-hmm.
So I do think family history matters. The guidelines say first degree relatives, but I also often include second degree relatives because, for example, if your dad had two sisters with breast cancer, you would just be ignoring that history if we
Mm-hmm.
didn't do that.
Mm-hmm.
So I think the age you start, if you have any family history, I would kind of discuss with your doctors what the best age is. Mhm.
Mm-hmm. And doctor, what is the percentage, for example, if a person has a positive genetic testing with BRCA1, BRCA2, that the other member of the families they have it or not? They have to do all the testing. Yeah, this is the.
Yeah. So this is a great time to kind of talk about inheritance a little
Mm-hmm.
bit.
Mm-hmm.
So, say my mother had the BRCA gene,
Yeah.
and every person is born with two copies of every gene. You get one from mom and one from dad. So if
Yes.
my mom had a BRCA mutation, one would be working and normal, and one would be abnormal and mutated.
Mm-hmm.
So my chance of inheriting that would be 50%. My children's chance without knowing my status would be 25%.
Okay.
And my mom's siblings would be 50% because they're first degree relatives.
Mm-hmm.
Now, say I had testing and I tested negative, then my children cannot inherit something that I don't have. So their chance would be 0%. So it can't skip generations, and
Mm-hmm.
it's something that has to be passed on. Very rarely, there are some rare genes that can start new in patients, but you don't usually see this significant family history. You usually see other findings that make your physician suspect that kind of thing.
Mm-hmm.
So the chance of someone having a gene in their family depends how closely related they are.
Mm-hmm.
And if the way they're related, through their parents don't have it, then they're not at risk. Mhm.
Okay, great. So, doctor, can you tell us the role of diet and nutrition it plays with breast cancer prevention based on recent research or studies?
Yeah, so I think kind of the old school of thinking was that it
Mm,
was all calorie based, and there is some truth to that because of body weight. And
mm,
so, like the older studies really just recommended, making sure that your body weight was in normal range and focusing on calories.
mhm.
But there were some really good studies that came out of France that looked at something called glycemic index. And
Okay.
what they've shown is that the type of foods do matter. So, say me and you are the exact same height and weight and same body mass index, but I had a very carb-rich diet. So lots
Mhm,
of pasta, breads, sugars, candy
mhm.
bars and Cokes for lunch, that
So
type of
sugar
sugar, then
mainly.
my risk would be higher than someone who had a more healthy diet of lean
Mhm,
meats, lots of fruits and vegetables, limited carbs. So I
mm,
think it's a combination of both. Like the calories and weight do matter, but the food quality matters as well. The World Health Organization also has shown that processed meats in high quantities or smoked meats can cause different types of cancers. So I don't think it's something that you have to completely avoid. But for example, like deli meat, maybe just limit it to 3 times a week. That number is just one of my suggestions, but
mhm.
it's kind of just, you don't have to be so all or none, but you can just kind of not do things that may not be the healthiest on a daily basis.
Yeah.
Mhm.
And what about intermittent fasting? What do you think about that? Does it help
Yeah. So,
prevention?
so I think intermittent fasting, there's a lot of studies that have shown a lot of benefits. I
Mhm,
think the greatest benefits are in patients that were obese and lost weight because it's been shown to help with dementia, strokes, cardiovascular disease. but a lot of these are related to obesity as well.
Hmm.
But I think if it's done in the right way, that it can help people have healthy bodies and lifestyles.
Hmm.
There's some people that have extreme ways of intermittent fasting, and I don't know that we know the long-term effects of that. But I do think if it helps people maintain that healthy body weight and lifestyle, it's good as long as you are getting plenty of water and fluids with it.
Yeah. And doctor, let us talk about triple negative breast cancer now. So we know that triple negative breast cancer is known for being very aggressive kind of cancer. What are the latest treatments? Can you tell us first what is it, comparing to other kind of cancers that are related to hormonal? They are affected by hormones, I think. And what are the latest treatments and options for this kind of cancer?
Yeah, so I would say triple negative breast cancer is kind of the scary cancer when people think about it.
Mhm.
And the reason it's called triple negative is because it lacks a target. So in breast cancer, there's three different markers we check for. Two are hormone markers, so estrogen and progesterone, and medicines that block hormones work very well on those
Mhm.
cancers. And the third is something called HER2.
Yeah.
And now there's some nuances to HER2, but HER2 positive has some very special targeted treatments that work. So in triple negative, there really has not been a true target,
Mhm.
and the treatment has really been mostly chemotherapy based.
Mhm.
So in the curative intent setting, there's a lot of recent trials that have shown chemotherapy in combination for stage 2 and 3 with immunotherapy is very effective.
Mhm.
And then if at we usually will do chemotherapy and then surgery. And
Yeah.
if there's any cancer left, you can either do a chemo pill for 6 months,
Mhm.
or if they're a BRCA carrier, there's a special medicine called olaparib that they can
Mhm.
take for a year, which really helps. So those are kind of the latest treatments for the curative intent
Mhm.
treatments. And there's a lot of research going into when at the time of surgery, there's still cancer cells left, so the chemo didn't kill them all,
Mhm.
and escalating care with newer and different types of chemotherapy in that setting. So, for example, we don't have the trial open yet, but we're looking at a drug called sacituzumab, which is very effective in the metastatic setting to see if it would cure more people of breast
Mhm.
cancer in the curative setting. So I think those are kind of the latest treatments, the immunotherapy, the PARP inhibitors, and maybe
Yeah.
bringing some of the metastatic chemo drugs like sacituzumab to the curative setting. We don't have any open at Baylor right now, but there's also some studies looking at vaccines to target residual disease and triple negative breast cancer. So that's very up and coming as well. And in kind of early stage trials, those seem to show some efficacy, but we'll have to see when we do like the big phase 3 randomized trials if that approach is effective or not.
Okay.
In the metastatic setting, we have a couple kind of new things that we're doing. So
Mhm.
we have the PARP inhibitors, just like we have in the curative intent setting. We have immunotherapy if there's a special marker called PD-L1.
Mhm.
And then we have found that with that drug Enhertu,
Mhm.
that even if there's very low expression of that HER2 protein, so where it's not positive, but if there's
Mhm.
any expression at all, that drug is very effective, which, is interesting, and it kind of gives another good
Mhm.
line of therapy for patients. And this drug, sacituzumab, that I mentioned, is something called a drug antibody conjugate.
Mhm.
So it's really neat because it can attach to the cancer cells and deliver chemotherapy at 8 times the dose that your body could normally handle.
Mhm.
And so it's like a very potent chemotherapy that's very well tolerated because most of the chemo is delivered to those cancer cells.
Yeah.
So I do think there's a lot of interesting new kind of drugs and data
Yeah.
coming out, but that's kind of the newest and latest that most patients
Mhm.
would have access to.
And doctor, if the triple negative cancer has been found at an early stage, do women have the same chance of getting rid of this kind of cancer as other kind of cancers, or it's um, it's harder, I mean?
No, absolutely. So if you look
Mhm.
at stage 1 and 2 breast cancer overall, the cure rates are 95%.
Okay.
So when we find triple negative cancers very early,
Mhm.
you still have to go through chemotherapy, even if
Yeah.
it's like half of 1 centimeter. But
Hmm.
the cure rates are very high. The ones that are harder to cure are the ones that have a very bad biology or are very large when they
Yeah.
present. And
Okay.
those are usually like not screen detected cancers. They're more like the palpable masses.
Hmm. Hmm. And doctor, how do you address the psychological challenges faced by these women that have been diagnosed at a later stage? I mean, at a not very early stage with the triple negative.
Yeah, so that's a really good question because mental well-being is a huge part of cancer care
Hmm.
and survivorship. So I think all oncologists will screen for things like anxiety and depression.
Hmm.
Children can be very much affected by, their parents and having a sick parent, and then imagine having a parent with metastatic disease, which
Yeah.
is not curable. So we do most cancer centers will have a team that helps us. So oncologists can only do so much, but we do have like psychologists that can help with talk therapy. Not necessarily, every person needs medications.
Yeah.
And then we do have resources like in I'm in Texas and we have a great nonprofit called Wonders and Worries where they kind of help children who have parents with advanced
Mhm.
cancers deal with that. And then if they pass, we have a wonderful place called Bo's Place that can do grief counseling. So I'm sure in other countries, I hope there's some similar resources that can
Mhm.
help patients in the same way. Mhm.
Mhm. And doctor, what is your finally, what is your advice to all women out there? Um, they are who are scared from breast cancer. I mean, every woman will have like this nightmare of getting breast cancer, I think.
Yeah, so I think my message is if you're listening to this, you're obviously worried, and I think knowledge is power. So when it's age appropriate, get your screenings every year, make it a priority, put it on your schedule, schedule the next year's when you're leaving, the following year so you don't forget. If you have family history, see if you can get in to see if genetic testing is appropriate, if you would benefit from medications for prevention or adding breast MRIs to your screening,
Mhm.
and just kind of use common sense. Live a good, healthy life. I think everyone knows what's good and bad for them in terms of like exercise and diet and the things we have to do. But I really do think knowledge is power and preventative care is incredibly impactful.
Mhm.
And most patients that are getting, annual screening mammograms, cancer's found very early. One of the limitations is dense breast tissue, and that's why I bring up if you have a strong family
Yeah.
history to consider, supplemental screenings.
Mhm.
But I also think we cannot control
Yeah.
everything. And unfortunately, cancer and illness is part of life. And if you feel like something is not right with your body or something's been going on, don't wait to go in
Yeah.
because the earlier we can find problems, the higher the chance of being able to cure it and get you better. Mhm.
Mhm. Thank you, doctor, for being with us. It was a pleasure having you, and thank you for the all the information you gave us also.
Yes, thank you for having me.
Thank you.